This podcast is sponsored by Blue Room. When lives are on the line, every second counts. Every movement, every decision, every breath. That's why Blue Room simulations exist. The world's most advanced mixed reality training simulator. Designed to put you under real pressure in real environments without the real world risk. So no bulky controllers, no gimmicks, just your hands, your kit, and a level of immersion that makes you feel like you step straight into the mission. One moment you're in the cockpit of a Black Hawk, the next in the KSO combat zone, or on the side of a cliff, training as if it's happening right now. So born in Australia, trusted across 5 continents, Blue Room is redefining readiness for military, medical, and frontline professionals worldwide. This isn't the future of training, this is training transformed. Step inside Blue Room Simulator, visit blueroomxr.com and request your demo today, or see the show notes for further details. So just before you hear today's episode, we're shining a spotlight today on the incredible initiative from the student paramedic group at Liverpool John Moores University. They've reached out to the podcast really just to shine a light on their award-winning CPR 24-hour marathon that they're doing this week on the 24th of October, Friday, 6 p.m. to the 25th of October, Saturday at 6 p.m. So teams will be performing continuous CPR for 24 hours straight. And this is really raising awareness for the life-saving skills and vital funds for the North West Air Ambulance charity. So alongside CPD sessions, emergency service demonstrations and free CPR training to everyone, they're hoping to raise £3,000 for North West Air Ambulance charity. So this year they're aiming to do it again. They did it last year. So please do head to the show notes. You can donate right now using the link in the show notes to donate to this fantastic initiative for Northwest Air Ambulance. Please do head over there and sponsor them. It's happening this week from the 24th to the 25th of October. Many thanks.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're exploring the evolving role of women in HEMS and indeed in pre-hospital critical care. So today, we're really going to document and do a deep dive into the insights of critical care Dr. Sophie MacDougall. We're going to hear Sophie's journey into HEMS and indeed how she's navigated her career path within Great Western Air Ambulance Charity or GWAAC. So from overcoming barriers and indeed difficult moments to the importance of mentors in Sophie's life, we're just going to walk through some of the critical lessons she's learned along the way and indeed support the visibility of the next generation of female critical care professionals. So welcome to the podcast, Sophie.
Thank you. It's really nice to chat. Thanks.
I just wondered if we could just kick off and start with really what drew you into a career in pre-hospital emergency medicine, and indeed how did those early formative experiences shape your direction?
It's interesting. I had a very circuitous pathway. So I actually did expedition medicine for probably a good 10, nearly, I don't know, going towards 15 years of kind of expedition medicine through medical school and onwards through all of my F1, F2 and ACCS training. And I kind of always thought that's where I was going. I was exposed to FEM when I started my ACCS training. And what I saw was these incredible GWAAC doctors coming in, all tall, beautiful, strong men. They'll know who they are when they hear me saying this. Coming into Franchise Hospital, and they'd done these amazing things pre-hospitally in difficult situations and brought in these sort of fully packaged, mostly treated patients. And I was just in awe of them. And I thought, firstly, that's something far more difficult than I can ever do. And secondly, it's probably a world where I don't belong, because most of these guys are military, and those that aren't are kind of proper, tall, strong men who are really clever and far cleverer than me. So it hadn't really occurred to me that was something open to me. And anyway, I'd always loved traveling and working abroad. And so I was doing lots of expeditions up in the Himalayas and the Andes, kind of in the polar regions. And so I carried on with that pathway happily until I met my husband, who was an expedition leader in the jungle. And I met him on a job out in Belize. And we carried on working abroad for quite a while together. But then I had a baby. And at that point, it wasn't possible to go and sleep in hammocks for 3 months in a row anymore. And I came back after a couple of years of traveling to do my anaesthetics training, and was really looking for kind of that buzz that you get from medicine in remote environments. And what happened was I was running a course with a very good friend who's now a doctor for Cornwall Air Ambulance, who's female, and I saw her do a talk, and she'd always been someone I'd held in incredibly high regard because she'd been an army doctor, she'd worked out in Camp Bastion, she's just an incredible person. And she did this talk on her time as a FEM trainee in the east of England, and it made me think, oh, this could be a good idea. Maybe I should start heading down this pathway. And that was kind of how I went towards it. So I suppose, yeah, in summary, I'd seen these amazing people that I never thought I could be, but then had this wonderful friend who had done it and kind of made me think it might be something I could go towards. And that was kind of how it all ended up. So yeah, I came to it very late, in my probably mid-30s by the time I started doing it.
Could I get you to speak to really, I think to your point, I think as you migrate through your career, Sophie, and certainly within FEM and indeed expedition medicine, there is maybe one or two seminal moments where you meet a patient and or family that really stays with you in your career. Could I get you to speak to one of those seminal moments that I guess in a way you look back on and think, this actually just makes a difference?
Yeah, I mean, gosh, there's so many, aren't there? Like, there's so many. And it's funny because there's kind of the huge heroic ones where, you're involved in a multi-casualty incident on the motorway and it's multiple kind of semi-arrest or already arrested patients. And then there's the ones that seem lower acuity at the time. I think for me, one of my biggest moments, and it's going to sound quite low acuity compared to what you might be imagining, was actually in London going to a patient with a physician response unit. So it's not actually a HEMS service. It's a kind of it's run by doctors, and the idea is to kind of redirect patients who might have otherwise called an ambulance and either treat them at their home and therefore avoid their need for hospital admission, or kind of triage them in the right direction. And I went with a incredible doctor who became a really important mentor of mine called Gareth Davies, who will be familiar to lots of people listening to this. And we went to see a patient with COPD, and they had a simple exacerbation of COPD. And he got me to really look at the patient, and he said, right, look beyond the chest, look into the chest, understand why their breathing pattern looks like this, understand what is causing their physiology and what we can do to make a difference to it. And it's funny, that was a moment for me where I thought, and we treated him, and we enabled him to stay at home with his family and not have to go on a big long hospital trip. Like, and he had multiple comorbidities, so it was really good for him that he avoided that. And it's completely changed the way that I practice medicine. And the way that I teach medicine to others, actually, because I kind of have stolen that bit of teaching from him, and I now have taught it to hundreds of other people. It's just that way of looking at the patient, seeing the beauty in medicine, understanding truly what's happening and what we can do about it, whether that's in a hospital or a pre-hospital environment. And it kind of brings that joy back. And yeah, for me, that was one of my most seminal moments in FEM, was a really simple, low acuity, unexciting, COPD.
No, listen, I think there's real power in that actually, Sophie, because sometimes the teachable moments and indeed the revelations come from unexpected places, absolutely unexpected places. So I completely resonate with that, and worked on the PRU myself in 2006 and 2007, and worked alongside Gareth Davies a number of times, and had plenty of those moments myself. But so just pivoting slightly and looking at, you've credited your mother, really a nurse practitioner, as a powerful influence in your life. Could I get you to speak to other mentors and or role models really that help guide your path into medicine?
Yeah, well, she was really important. And I think both my parents really, in that. And I've reflected on this quite a lot because as we're discussing, and the reason why I'm here is FEM is quite a male dominated specialty, and people often say, how does it feel? Were there lots of challenges and things you had to overcome? And the funny thing is, like, for me, the answer is actually no, there weren't a lot of challenges, and I never really felt there were barriers. And I think that's because my dad was an English as a foreign language teacher, so he taught students coming from abroad, and my mum was a practice nurse and then did her nurse practitioner bits as well. They just made me and my brother feel like there wasn't a difference. And the funny thing is, for me, it only occurred to me there was a difference in being female and male when I got pregnant, because that was finally the time that something happened to me that couldn't happen to a boy. And therefore, I had to make allowances. I had to take time off to have a baby, and I had to breastfeed the baby and all of that. And until that moment in life, I think I just always felt that everything was open to everyone and it was okay to have a go. I mentioned earlier that I kind of saw these big, strong men doing Fem and thought I couldn't do it. And that wasn't because I was a girl so much as the fact that I wasn't 6'6" and in the army and strong and as clever as them. But being female, I think my parents just always treated us equally, encouraged us to do whatever we wanted. My brother did fencing. I wanted to have a go at fencing, so I got some fencing foils, realized I was rubbish, stopped doing it pretty quickly, but like was still encouraged to do it because I wanted to. I played football. I was the captain of football at school and stuff. And it just I don't know. I think that's a huge important thing. And my mum took me into her work when we were doing work experience, and I saw what she was doing in the GP's practice, and I met the doctors there. I also had really amazing teachers. I went to just a local state school in Oxford, which was brilliant, and I had some really inspiring teachers who just treated everyone equally. There was no difference if you're a boy or a girl. And in particular, I had a chemistry teacher called Professor Ryan, who was just really enabling. And I suppose it was all of that just kind of, I didn't feel like it was something that wasn't an option.
So interestingly, you speak of that, and that's interesting to me for a number of reasons, because your career reveals the pivot you've taken, Sophie, before Fem was into expedition medicine. And actually, expedition medicine is super challenging for a number of reasons, because low resource environments, protracted times to definitive care, a sparsity of diagnostics, and you're there with a finite medical kit in some of the world's most extreme environments, polar regions, jungle regions. So in essence, that was probably, and I'd love to get your thoughts on this, a good training ground for Fem, because you don't have the diagnostic abilities that you do in hospital. You don't have the CT to hand. You don't necessarily have the blood work to hand, and or expect a large amount of resources and or staff to draw on. Could I get you to speak to that linkage, because there's some real lessons you've probably pulled through from expedition medicine into Fem?
Yeah, I think there's a huge linkage, isn't there? And I think that Fem and expedition medicine tends to attract a similar ilk of people. And it's almost a personality trait, not just something within medicine, because it's people who are happy to act in uncertainty, make quick decisions in sort of time critical situations where you don't have all the information and you're going kind of on your gut feeling, take risks that are calculated. But like, so in expedition medicine, everyone who's there is there because they're taking a risk. If they're going to high altitude, if they're going on, into, I don't know, deserts or jungles where there's lots of snakes, they know there's a risk, there's an inherent risk. And so you can't take all of that away. You can't make something no risk. And so you're always acting as the medic, kind of trying to keep people safe whilst accepting you're in a high risk environment. And yeah, I don't know. I guess that's something I've had all my life, whether that's from lots of camping trips with my family, or whether I think also my school were brilliant with Duke of Edinburgh. We did loads of that, and that was really, really exciting. Age 12 or 13 or whatever it is, being turned loose in, I think it was the New Forest where I first went, with a tent, a load of friends, and some, cereal bars to survive for 3 days. That's just, it becomes quite addictive. And people I know who do Fem and who do expedition medicine, we all have that similar kind of pull towards difficult environments, challenging situations, kind of rising to the occasion. And when you're cold and wet and soaked through and haven't got any dry clothes or any food left, it's finding ways to thrive in that. And Fem's a bit like that. You're on a motorway at 2 o'clock in the morning in pouring rain, up to your knees in water in a ditch, trying to get someone out of the car. And you work with your teammates, and it's incredibly powerful because you're committed people who are trying to work together to do something really important. And it comes, there's nothing more important than saving someone's life and making them feel less frightened in what's probably the most frightening situation of their life to date, and doing that with somebody else who's equally passionate and cares and problem solving and, you know, making quick decisions is, yeah, I don't know how to describe it. I suppose it's just something that once you start doing and you realize A, you enjoy it, and B, you're, you know, reasonably good at it, you can't think of anything else you'd rather be doing
Yeah,
with your life.
indeed. Yeah, indeed. I totally agree with you. And there is a lot of crossover. And I think it's actually the converse. I actually think that expedition medicine can be maybe even more challenging than FEM sometimes, because you've got less diagnostics, less
Mm.
resources, and actually you're not necessarily part of a small trained team. You almost in some regards are an island, and
Yeah.
you've got a lot of non-medical personnel around you. Could I get you to speak to some of the most rewarding and or challenging aspects of Sophie? One of my revelations was just how palliative FEM can be. Just the no matter what you do, the trajectory of care can't necessarily be altered. And I
Yeah.
always struggled sometimes with that. You could throw the book at, or indeed the whole ambulance at a patient, and it still wouldn't necessarily make a difference. Could you get to
Mm.
speak to some of those highs and lows?
Yeah, I mean, it's interesting, isn't it? Yeah, we have the highs and we have the lows. And I think for me, like as an anaesthetist as well, and as a fem doctor, you're seeing people at a moment at which they're at their most frightened. You know, that moment before they go to sleep to have their cancer surgery or to have their life-saving aortic aneurysm repair, which they know they might not wake up from. I see it as my job. It's not just to give the anaesthetic; it's to give them compassion and care and love, and make them feel safe. And fem is a bit like that, because you're seeing people on, you know, the worst day of their lives, and you're trying to make them feel safe as well as give them all the treatment that they need. Um, and there are highs and there are lows, and that's the reality of our job, is that a lot of the patients we look after don't survive, and it's not just about the patient and throwing the book or the ambulance at them, as you rightly say, but it's about looking after their relatives as well, and about making that awful moment for the relatives, knowing that their loved one isn't going to survive this, as least traumatic as possible. And obviously, it's going to be horrendous and traumatic, but it could be made so much worse. My mum talks about when her mother died. It was awful. It was all a really drawn out, unpleasant death in hospital. And as a nurse, my mum felt really unsupported by the team there, which was really sad for her. And she went in the following day to get the death certificate, and she saw the doctor and the nurse in the doctor's office laughing when they were asked by one of the other nurses if they could write the death certificate, and they kind of waved their hand and waved the request away. And the reality was probably that they were tired, it was their coffee break, and they wanted to just wait 10 minutes before they did it. But my mum, what she saw was some people who didn't care about the fact that her own mother had died in a really traumatic way. And that for me has coloured the way that I act forever as a doctor. And I make sure that every single patient I look after who's receiving that kind of bad news, and the relatives particularly, that I just treat it as if they were my own family and I was telling them that, you know, that terrible news, and that I really care about it, because I do think it makes a difference to the way that they process their grief. And I think that's kind of our responsibility as fem paramedics and doctors to deliver that sensitively and to really look after them in those moments, and to make them feel that we've done everything we possibly could and that it was peaceful, and make it as pain-free as we can. And then the highs that you mentioned, it's you know, it's a toss of a coin, isn't it, whether those moments go well or don't go so well. And in the moments where they go well and you get somebody back, we had someone recently, a gentleman in his 60s who'd had a cardiac arrest on a roundabout whilst he was cycling, and we got there. We were actually the first on scene, and were we, or were we not? I'm sorry, they all my memory's never very good. I've got 3 children, so my memory doesn't work properly. But we arrived, I think the police were there, but maybe we were the first medics on scene. But anyway, we resuscitated the gentleman, and we got a really good outcome. And we took him to the cath lab, and he got angio straight away, woke up the next morning and went home a few days later. And he then came into the base to see us recently, a few weeks ago, with his wife and his son. And seeing him suddenly, completely alive and chatting to us with his wife and his son, who's in his early 20s, and thinking, those people have got back their husband and father for the next however many years, and seeing the closeness of their relationship together and how grateful they were that things had been turned around, not just by us, but by the whole team that were there on that day and by the Angio people and everyone. That is amazing. And that's what makes it so incredibly rewarding, is to kind of see the really human aspect of what you're doing, and that you're giving a family back their wholeness.
Yeah, absolutely. It's profound, actually, Sophie. And I think as we're seeing the adage of patient liaison services come into fruition, that there's starting to become more the standard of care that HEM services are having patient liaison. And to your point, though, Sophie, I think it benefits the clinician equally as much as it benefits the patient, because for the patient, maybe it's filling in their journey. But for the clinician, as you're saying, it kind of just reminds you of the power of the work, and actually giving that father back to the family and that husband back to the family is just irreplaceable, and gives you that profound sense that actually, to your point, what you do matters, actually, and it matters, and the reverberation of that echoes on. So if you could, I get you to speak to, because FEM is challenging, and to your point, busy life with 3 kids, and there is sacrifices you have to make. You're at 2 a.m. on the roadside in the dark, in the rain, weekends, late, early nights. Could I get you to speak to how you sort of balance that sacrifice with having a family with 3 kids, which is super busy? Just how do you sort of strike that balance?
Yeah, it's really challenging. It's really difficult, and I suppose a lot of the time I feel like I'm not the best parent, and I'm not the best wife, and I'm also not the best doctor and not the best colleague. Because in my mind, to be the best colleague, I'd have to have no outside commitments, and I could cover any on calls that needed doing, fill any rota gaps, and be there all the time, and always be the one that stays late. To be the best wife, I'd need to be here all the time and be with my husband all the time. And to be the best mum, I'd need to not have a job and be looking after them 24/7. And you can't, but all those things are not mutually, all those things are mutually exclusive. And it's taken me a while, and having really helpful chats with mentors, to kind of untangle this and start realizing that it's just a case of juggling things, keeping it all in the air somehow, and trying to give everyone enough attention and love. And now with 3 growing up children, I've got a 9-year-old, 7-year-old, 5-year-old. I can see them out of the corner of my eye on the trampoline doing God knows what. To sort of balance that with a career in FEM and still feel like I'm competent, up to date, safe, and a good doctor who I would want to treat my parents if they had a problem, or my children if they had an accident, is a constant challenge. And I think the way I do it, my work in the hospital has been really understanding. My clinical lead has let me drop some sessions at my base hospital, so that my now sessions with the base hospital combined with my air ambulance makes a full-time job. But otherwise I would have been doing the air ambulance on top of that. As well as that, GWAAC have been incredibly supportive and understanding, and have been really helpful at kind of making the rota fit and the number of shifts that I do, and making it work with my base job and my family commitments. My colleagues at GWAAC are just amazing people. And my husband obviously is a legend, and he married me knowing what I do, and knowing that there was no way I was going to stop doing all of it. To be fair, he did marry me before FEM, so that wasn't part of the contract. But he did marry me knowing that I was an expedition medic, so I'm hoping that it was the swap of a like for like. I'm not going to lie though, it's been really difficult. There's been times when it's been really, really hard, and I haven't been giving enough of myself at home, and that's been really difficult on my husband and the children. And that experience has taught me that I need to find ways of balancing it, and that is the reason for reducing hours and doing less shifts overall. And I think I'm kind of just about finding a happy balance between the 2 jobs and the family. Yeah, sorry, I'm rambling away because I probably haven't quite got to the perfect point yet, which is why I'm not giving you a straight answer.
No, to be honest, Sophie, it's the perfect point because these things are messy. Like you said, actually, it's really challenging being pulled in so many directions and feeling like you're acing or absolutely smashing each, which you know, I think is it's a really honest answer, and it's actually something I can certainly identify with, and others can, I'm sure, because there is multiple demands on your time, and it's challenging, just course correcting and recorrecting that balance sometimes. So I can completely identify. You've spoken about mentorship, you know, just the influence of your mother. You've spoken about Gareth Davis and his profound experience, his profound influence on you. Could I get you to speak to just the importance of mentorship? And I guess the loaded question here is just the importance of people seeking out mentors, just to really, in a way, vicariously sort of osmose some of those character traits that's been shown to you over time.
Yeah, I think that's it, isn't it? It's seeking out. And I think I've I feel so grateful for the mentors that I've had through my life. And if I shut my eyes, I have flashes of the people that have really influenced my life. So, my art teacher at school, my chemistry teacher at school, my mum, my dad, my uncle and aunt. And then going forward, my oh, I've forgotten the name for him, but the dean, yeah, the dean of my medical school in Oxford was incredibly influential for me. Like he really inspired me. Um, yeah, he was amazing. And various teachers along the way, one of my clinical teachers at Oxford. And then as I've gone into my career, what happens is you kind of have these moments where you feel like a connection with someone or someone really almost like a magnetic attraction to somebody, thinking, okay, I see similarities with you and I want to be like you when I grow up. And then hopefully, luckily, they don't think you're a weirdo for fangirling them. Instead, they're like, oh, I'll take this person under my wing. And so that's kind of happened to me along the way. And it's give and take, isn't it? Because it's not just that you can suck onto them like a limpet and try and suck out all of their goodness. You give back. So if you're on a shift together, you do all of the crappy stuff and you fill out all the forms and you kind of show huge enthusiasm. And then in return, they want to impart things on you. And it's mentorship is a two-way conversation in that. So I'm lucky now because I've been mentoring people, and the people I most enjoy mentoring are the ones where you really feel like you're seeing something back of their soul and of themselves and of what they're aspiring and dreaming of being. And so that's what I think you have to look for. So I guess if I was advising people from the beginning, earlier on in your career, is look for somebody. It doesn't have to be the same sex as you. So some of my greatest mentors have been male, and it's looking for somebody where you feel inspired by them, you feel energized by their presence. You're looking at how they perform as a human being and as a doctor, and think, wow, I really want to be more like that. And they might also have great insight into sort of your motivations in life and medicine. And you might have a chat, I don't know, and the car ride to a job or something, and you think, wow, that really resonates. And then at that point, you can either sort of hope those chats continue, or you can actually say, look, I found that really valuable. How would you feel about kind of unofficially having some further mentor chats? Would that be all right? And I've tried that a couple of times and people really like it. Like, I think it's quite flattering for people when someone says that to you. Um, and those relationships have been some of the most powerful for me and really shaped where I've gone. And I hope that now I'm taking on some of those relationships with more people further at the beginning of their careers. And I hope that I'm being able to impart a little bit of that too. And it's about joy, really. It's about sharing the joy of a career in medicine, fem, paramedicing, whatever it is, and also a joy in just the relationships that we have with people along the way.
I really resonate with that actually, Sophie, and I hope you won't mind me mentioning him, and you might have bumped into him as well. But a fantastic GP called David Whittington, who used to work on the PRU in Whitechapel, was exactly that person to me, with just this amazing bedside manner, and we co-respond as the paramedic and indeed as a GP, and just that vicarious learning from the way he actively listened to patients and to your point around, you might not be able to fix the end state or indeed the chronic pathology, but the patient just felt listened to. There was resolution, even though if you couldn't fix the overall pathology, they felt that they had a fundamental consultation that there was some resolution to, and that those non-technical skills, and I would do everything in my power to be alongside him on shift, just to learn the way he moved, the way he listened, the way he reiterated message, the way he verbally de-escalated crews and the patient, and all those, you're right, all those skills you don't necessarily learn at medical school or indeed at university. And I just thought, gosh, this is medicine. This is what I'm missing, is the ability to take the temperature of the room down, really slow the cadence of communication, bring people to a place where they feel the fundamental worth. And actually, even if you can't fix the overall state, there's something, there's an exchange, as you were saying, there's an exchange between you and the mentee, but there's an exchange between the patient and the clinician, and they feel like they've come away in so much way better than,
It's
it's
so
powerful.
true. It's so true, and it's so powerful. And I see people like that, like people like GD and Dr. Whittington, and I kind of feel like I know I can never be like that, but how can I just try and absorb a little bit of that and try and channel a bit of that? And when I have my best interactions with patients, I kind of think, actually, that was me kind of channeling some of my greatest mentors and the people that most inspired me. You know, 5, 10, 15, 20 of these people are all kind of, I've taken little bits of what they've said and done along the way. I've tried to imitate it. And that's why that interaction was good. And you kind of start to see yourself as the product of all those different people that you've been lucky enough to learn from and be steered by along the way. And yeah, for me, it's funny. A lot of those, I don't know, it's been 50-50 male and female. It really doesn't feel like you have to find mentors that are physically like you at all. It's just more about that kind of personal connection.
Yeah, I completely agree. Completely agree. Sophie, just as we finish off on the conversation, just one final question really would be, just because what I love about the interview and some of your answers is you did have and do have this can-do attitude, and I think that needs to be embodied across the specialism, really, male and female. But could I get you to speak to really, if this was maybe on the radar for women in medical school, could I get you to speak to just really advice you give to aspiring women, just that might consider moving into postpartum emergency medicine?
I'm so passionate about FEM. I have found it later in life. I absolutely love it. I feel like I utterly belong. And in my unit, it's so supportive. GWAAC is one of the loveliest, happiest places I've ever worked. It There are lots of women here. Everyone feels really included. I did a shift on Friday 2 days ago with it was a female paramedic and a female trainee doctor and me, and a lovely male pilot. And it isn't as male dominated as people might worry about. And also, you don't need to be, big and tall and strong and incredibly dominating to do FEM. And in fact, if you're not, you bring something quite special and unique that we really need. And as I said, some of the most important parts of our interaction in FEM is kind of bringing that compassion and care and taking away people's fear and reassuring them. And so my message to girls who think it might not be for you is it absolutely is. It's a lot of fun. Yes, you need a can-do attitude. You need to be prepared to stand in the rain at 2 o'clock in the morning. You need to be prepared to be kneeling in a field of cowpats, or like on Friday, I went to another job in a mountain biking park where we were just covered in dust and people, like on a mountain biking ramp with somebody who'd broken their femur. You need to be prepared to do all of that and wear horrible steel toe-cap boots that are very uncomfortable and an extremely unattractive orange uniform. But if you can deal with that, then girls are totally welcome. The boys will make you feel welcome. And yeah, it's just a really, really brilliant specialty where if you're that sort of personality type that we've been discussing in this chat, you will feel right at home. You'll be with your people. And it's one of the most rewarding things. I love it.
Listen, thank you, Sophie. It's just great to touch base with you, get some of your revelations and indeed insights into your career, but also into fundamentally into your role at GWAAC. So listen, thank you so much.
No worries. It's so nice to chat. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.